Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. We are happy to have you tuning in with us. Today we have special guests Jennifer and Hammam. They're going to talk to you about catheter-to-vein ratio and what their future recommendations are for practice. Welcome to you both. How are you today?
Hi, good morning, Derek. We're okay. Thank you.
Fantastic. So welcome to the INS Infusion Room. Do you want to give a brief introduction and tell the audience where you're joining from today?
Yes. First of all, thank you, Derek, for having us today. It is such an honor to join and have this collaboration with you. My name is Jennifer. I am originally from the Philippines. I have been a nurse for about 22 years now. I graduated my Bachelor of Science in Nursing at University of the Philippines, and then moved here and started on different, areas. I started to work in medical floor, went up to ICU and PACU, and then vascular care. I also hold a degree on nurse education, hospital administration, and quite recently, my adult gerontology acute care nurse practitioner, which I am also certified along with my VABC. As of that 22 years, I have been, as I have mentioned, gained experience to several areas, and I have loved being a nurse, and I am looking more years of practicing in this profession, especially in the vascular access practice.
Thank you.
I currently work in MD Anderson as a clinical outcome specialist. I have been in this team for about 8 to 9 years now. I started being a staff nurse, inserting PICs, performing CVC maintenance care. And then about 4 years ago, I moved and stepped up on this position as initially was clinical development specialist, and then to COS, which is a clinical outcome specialist. And my partner, Hammam.
Thank you, Jen. Thank you, Derek. First, really, I would like really to thank you so much for having me on this podcast. I truly appreciate this opportunity. It's truly an honor. My name is Hammam Ahmed. I graduated from the Jordan University of Science and Technology in 2000 with BSN. I earned a master's degree in nursing education in 2017. I have approximately 20 years of nursing experience, mainly in emergency room, intervention radiology, education field, and vascular access PIC team. I hold several board certifications, infusion, CRNI, vascular, VAPC, CCRN, and CRN radiology. Currently, I work at MD Anderson Cancer Center as a clinical outcome specialist for about 3 years. And I just started my PhD degree in nursing education field. As Jennifer said, we are clinical outcome specialists. That means include education, quality metrics, and development of policies and SOPs related to the vascular access PIC team. And I'm sure Jennifer will give more details about this. Yes.
Great. Tell me a little bit more about your organization, if you don't mind.
So MD Anderson is a leading cancer network in the nation, or the whole world, I would say. As for our team, let me give you a brief history of vascular access and procedures. We are the biggest vascular access group. We started way before, I think, 1978. We had Mila Lawson as the first nurse to insert a PICC line. So it happened actually here in MD Anderson. We are previously called as infusion therapy team. And then about 5 years, we changed it to a vascular accident procedures as we are expanding our services. We have about 70 nurses. We are the ones performing insertions of central lines. We have APPs working for us for our subclavians and IJs. And for our nurses, we are the ones who are performing PICC insertions. In
And
addition,
you said 70.
seven, yes,
Wow.
70 nurses. Yes.
Impressive.
In our daily workflow, we have about 28 to 30 nurses because we cover the entire hospital. So we are also mobile, and we have 2 outpatient clinics. We have 2 buildings we are servicing all vascular access because as cancer, hospitals, 99 of our patients has a vascular access in one form or another. It could be a PIV, it could be a central line. So we all manage those. All CVC management is being done by our team. So our team is also very much involved in, designing algorithms to make our specific steps available to nurses, especially in the clinical areas in the inpatient. So they are guided on how to intervene or how to make decision, or if they have to escalate it to our team. We are also very engaged on every institutional policy because, again, in one form or another, there will be a vascular access for each of our patients. So we want to make sure that our practice is integrated in all the policies so they know how to better guide and navigate our patients. For example, they have to go to CT scan. So what do you have to do? They will have to go to us first, especially those patients who have, we'll call them like a hard stick. So for us to increase our patient experience, we want to make sure that we only do one stick. And all our nurses are very much skilled in US guided PIV insertion. So when it comes to that point, we have to come in, even with chemotherapy infusion, it could be TPN or any vesicants, just because we are very mindful of our patient safety in terms of extravasation, infiltration. So we have to let them know that we have that service. So we have to be very much involved in all our policy, including nursing care given to each and every patient.
Wow, that is so impressive to hear the organization's dedication to the specialty. That says a lot. I'm sure along with the increased safety comes increased satisfaction
Yes.
with your patients.
Yes, definitely.
Sick.
Yes, we are all for one stick because, our patients have been, they would say, because of the treatment, they could have been poked and prodded for a lot of time. So we want to make sure that it's not only their satisfaction, we are elevating their patient experience. It's the whole totality of their experience in their treatment. Having cancer is already your anxiety could be high. So in those small care that we provide, we want to make sure that we can extend the care that we have for them, that instead of being poked twice or thrice.
So I'm still stuck on this 70 nurses
And expanding.
team. I'm amazed. I remember working on a vascular access team, and we had an organization. Our hospital had about 300 beds, and sometimes I worked by myself on my shift,
and that's hard.
So, and that's all departments. That's outpatient, that's inpatient, difficult. Sticks, it's evaluations, it's new orders. All that was on sometimes just myself. If we were lucky, we had 2 And I think that's the case for a lot of our vascular access nurses out there.
Okay.
So this is very enlightening. And I think that there's a lot of takeaways in that to really talk about the value associated with pouring into that program and expanding programs to ensure that this is a true specialty and deserves
Yes.
the recognition.
It is.
You.
It is. And the type of care that we provide, because we're also 24/7. We have outpatient clinics during the day and we have night shift. So that even during the night, if they ever come up with problems with having vascular central line, they know that our clinical nurses have support. Like, okay, what do I do? They can always contact us because we also have a night shift. And the care that we provide may be minute to some, but it's actually a big help for our patients. So we're all on that. Patient safety and patient experience and satisfaction.
Wonderful. I could talk about this all day.
Yes.
Episode regarding that, but I want to hop into the work that you completed. So when I originally read this work, I was very intrigued because there's a lot of discussions about catheter-to-vein ratio. What does it mean? How do we measure? What are the standards behind it? And what does it prevent by doing it correctly? And the validation important. So in the standards of practice, there is standards associated with catheter-to-vein ratio measuring and ensuring that we have enough blood flow around a catheter is essentially what we're trying to focus on to prevent any type of complications. So tell me about your work. What led you into studying this, and what did your work consist of?
Sure. I'll start, Joanne, if you don't mind. As you say, our study title is a comparative analysis of CVR definition and calculations, diameter-based versus area-based approaches. And the study will be presented at INS annual meeting in April.
And we don't want to give away too much details, right?
No.
Just enough. The behind the scenes part, but there's going to be a lot more if you come to conference.
Yes.
And that's
Yes.
right. So
I agree.
It mainly examines and compares the two key studies, Sharp 2015, which introduced the 45% CVR threshold, and Spencer 2017, which proposed a widely used area-based calculation table. So the comparison focuses on three main aspects: definition, formula, and methodology. Based on our analysis of the strength and weakness of each study, we will provide recommendations to improve understanding and practical applications. While the specific will be covered in details during the INS annual meeting, we would like just only to highlight and address broader concerns related to this topic. Sure. These points will clarify our evaluation methodology. How we started, I'll leave it for Jennifer, because there is a story behind this study.
Yes. So when I and Hammam assumed this position in 2021, we had to redesign or redesignate all of our SOPs because at that time, I think with the INS new guidelines in 2021, we had to make sure that everything is aligned with the best practice that is recommended by INS. INS.
This was completed. This was completed during that time frame before the standards of 24 came out, correct?
20. Yes, some of them.
That's what we thought.
Yes, we just.
You were looking. So we're now in 24, but we were looking in 21 at that particular time.
Yes, so because that's when we assumed this position. So we said, okay, let's make sure that everything is aligned. We give a lot of credit to INS for guiding our practice because we, as a governing body of our vascular practice, we look up to what's a standard of INS and what's the recommendation, because we know that these are all evidence-based, well-studied. And then we share your vision of having, patient safety at all times. So when we were looking at it, we had to include what's the definition and what is the formula for the CVR, because we had to incorporate it. We have been doing it, but it was not well established and written in our SOP. So we said, let's make sure that it's our practice is well established in written forms of our SOP. So it's
So
it's
elaborate a little bit more on how you were measuring the CVR.
yeah. So we have had BD, our what you call this, our ultrasound, or BD and sonocyte. We have those calipers already. We're doing it, and we're looking at the table that we've found. That which the green section and the red section, and we said we had to include it in writing that we are using this formula. So when we are now getting the definition and the formula, that's when Hammam said, okay, this is a good table, and we are following. However, when we looked at different definition and equation, we were like, we are comparing apples and oranges. So we said, okay, we can harmonize it just like what we did in the study, and says, let's see if it's gonna meet at that point where, it's still the same with Sharp and Spencer is talking about it.
Can you
But
talk
then we just
what
had,
those differences are?
yes.
So we talk about apples and oranges. What were those key differences?
Sure. Can I take over? James?
Yes.
So that's so Jennifer sent me first at the beginning. She found a clear definition in Sharp study, very clear definition. I'm sorry, sorry. She found a clear definition in Spencer study, 2017. And then she told me, Hammam, I couldn't find CVR calculation clearly. So I was searching in Google, then I found the Sharp study mentioning it clearly, diameter over diameter. So I sent it her by email. I did not read the policy. She did not, she put it. And before we submit, I was even off that day. We review it. And then, the definition again from Spencer and the equation from Sharp. I emailed her quickly. I said, don't submit, please. They are like oil and water. Don't mix. So I told her, my advice is either you delete the formula, no need to just only be with definition, or delete the definition and keep the formula because they are not mixed. And then she called me why. Then I told her, okay, let me start with this analogy. My brother in Canada, and imagine he text me and asked me to send him $100,000. Simply, I'm gonna reply to that text. I'm gonna say, how much do you want? Maybe he will be amazed because he said, come on, Hammam, I told you $100,000. I said, no, this is not enough. It's not clear for me. You have to decide either Canadian dollars or US dollars because the currency here are not the same. If you ask for 100,000 Canadian dollars, at that time, I'm going to send him around $69,000, $70,000. While if you ask for $100,000, that means you're asking around 143,000 Canadian dollar. And this is what really triggered this study.
So the two different equations that are associated in the studies you were looking, given different answers. So depending on which one you were using, you were getting a different outcome as to what that CVR truly was.
Yes, 100% correct. And this is led us to ask first, what is the definition of CVR? Sometimes we found some author says the definition of CVR is a ratio or a proportion between PIC catheter and the vein chosen for insertion. And this is the same as what we said in the example. This definition will be incomplete. We should specify which factors are being compared. And again, we can say it's one dimension, like diameter, length, circumference. If the PIC related to the vein is okay. You can say area, cross-sectional area. You can say a volume, cylinder, the tube. You can say pressure. of the vein related to the pressure in the catheter or flow rate. However, you need to be specific. You need to give us a definition, specific definition for CVR. Why the definition is important here? Because if the author give me a definition, the readers need to ensure that definition aligns accurately with anatomical, physiological, and biophysical principles relevant to the catheter and vein. And by that definition, it allows us to derive an appropriate and straightforward equations. What I mean, if the author give definition and give equations or formula, we need to ensure that equation aligns with their definition. If there's any deviates from that definition, a valid scientific justification is needed and is mandatory. Let me give you example of this. If you ask me, hey, Hammam, tell me your calculate the house area, your house area. Then I start measuring the area of this office, like length, width, multiply. Then I say, okay, it's 100, multiply it with the 24. Immediately, you would question this method. You're going to ask me, why did you measure this office? I'm asking your old house. And why did you multiply it with 24, not 30, not 50? If I tell you that the architect who designed my house confirmed that the total area of my house is 24 times of area of my office, at that time we would accept my method. So it's very important to have a clear definition and clear equations align with their definition, and that definition align with all factors relevant to the catheter and vein.
Sure.
And the second point is the definition of CVR cutoff or threshold. It's not the same as the definition of CVR itself. Why? Because we add a word or term cutoff. And as we all know, many studies shows the relevance between CVR cutoff and thrombosis. It's almost now as a fact. Even we say like CVR cutoff is considered a key predictor of thrombosis or clot formation in upper extremity. Okay, so we say cutoff is directly linked to thrombus formation. The problem here is the word of thrombus. It's not really a word. It's not represent a sentence. It's not represent a page. It represents a chapter, because the clot development is influenced by many, many, many factors, such as patient-related factors, catheter-related factors, vein-related factors, biophysics-related factors, biochemistry-related. Why I'm mentioning these factors? Because I need the audience, every time I say factor, to ask these questions. Is it realistic to have just one magic CVR threshold that fits all patients? For example, is it the same threshold be applied to a patient with coagulation disorders, has history of DVT and pulmonary embolism, and undergoing to chemo, and not good with hydration, drinking water, and cannot do any exercise? Is that CVR cut off same to the patient, young patient who is always well hydrated and exercise and no medical history? And before we highlight like the last point, which is statistics in this study, I really want to highlight the magic word you mentioned, which is one of the most important factors, the flow rate. Because most, if not all studies talk about this topic, mention the flow rate and their chow traits, like Sharp, Spencer, even Nifong, and I really love all these studies. Nifong in 2011 conducted a really very nice study, which is he discussed mathematical fluid mechanics law, and he did experimental simulation for that to discuss the flow, the relationship between the flow and the clot formations. And all of them says, Virchow's triad, Virchow's triad, Virchow's triad. You see, like copy paste. Perfect. What's Virchow triad? One of the most important factor is stasis, hemodynamic changes. Is it like turbulence or the parabolic inflow rate or something like? Stasis is one of the core of virtual triads, and we know this is not really for Virchow. It came after decades from Virchow. These factors, they concluded from the Virchow studies. It's like always when I remember Virchow, I remember Mendel in biology. After a decade or 100 years, we discover his laws about the biological recessive and dominant, the three laws of Mendel's. However, so Dr. Nifong, he said, and he proved by simulation experiment and by mathematics, is if the diameter decrease, the flow rate will significantly decrease. Perfect. But I was like, I was waiting for him really to discuss the blood speed, because the blood speed is not the same as flow rate. And when I say speed, I know, maybe we're going to upset the people in physics who specialize in physics, because we don't have something speed in physics. Or like when you say like average or you say size, this is like we call it public terminology, because there is the speed should be with direction in physics. And we call it velocity. Velocity is a speed with direction. Why? Because in physics, if you go to the left, that means you're going to be minus. If you go to the right, that means you're going to add on. So, but here, because we talk in general, I would like the audience to excuse me. We're going to talk in general. Like, for example, when you say flow rate change, flow rate, flow rate change. If you say the rate or change, that means you cannot say equal V multiply A. You need to say equal delta, which is the changes between 2 points, because you say rate, derivatives, trend line. While we talk in general here, we need just to simplify the idea. So we're going to talk like we can call it speed. Dr. Nifong, he said it's expected or presumed that the blood flow will decrease and potentially it create venous stasis. How we know stasis is inversely directed with a speed. What does it mean? If you have high speed, you decrease the stasis. If you increase the numerator of the stasis, you increase the stasis, you decrease the speed. They are inversely. So he said potential. Then in the other two studies and many studies, copy paste, there is possibility of increasing stasis. The potential increase venous stasis. And the question here, why we cannot measure the most important things, which is the velocity or the speed, the blood speed around the catheter. Why I'm saying that? Because in general, we have two theories here about the blood velocity. And the blood flow is not equal blood velocity or blood speed. Blood speed is part of blood flow. So, to make it very simple, what is the flow? The flow, it's a volume of blood crossing per certain time. And this is how we do most of the physics law. Like, what does it, how we calculate the speed? What is the speed? The speed is moving object, like walking, from this point to this. So this is distance per certain time. Perfect. So the speed, very easy. D over T. Perfect. So the flow is volume over time. Perfect. And then we can define the flow is the speed of that volume of a blood in a cross, in a cross-sectional area. So flow Q equal A multiply V, which is velocity, the speed. Now, let's make it very simple. If I say 10 equal 2 multiply 5, 2 multiply 5 equal 10, correct? So if I decrease the area from 2 to 1, that means I have the speed is going to increase. The V is going to double. It's going to be 10. What does that mean? 10 equal 1 multiplied 10. Before, it was 2 multiplied 5. I'll give you very easy example. We've seen it, everyone saw it in their life. When you want to, if you have a water hose and you want to make that water to push further, what do? You put your finger on the at the tip of the hose, correct? So that means you decrease the area. When you decrease the area, if the flow is constant, that means the speed will increase. So you're going to increase the kinetic energy, you're going to increase the speed, you're going to push the water more. So one of the theories says if you put the tube, you decrease the area, that means the blood speed should increase, not decrease. And this is, I've seen it clearly when I did assignment in 2017, when I was doing my master degree. One of the book, as I remember, is Cardiovascular Physiology Concept for Dr. Richard. He's professor in anatomy and physiology. He's MD doctor. And he used this principle, which is the continuity law, we call it, which is if the flow rate is constant, you decrease the area, the speed should increase. And of course, by also Bernoulli, he said, if the area decrease, the pressure will decrease. And he said, if you have a vein or artery and there is like stenosis, the blood will increase. The velocity of blood should increase. That means it's going to decrease the stasis. However, Dr. Naifong, and I agree, and I'm sure even Dr. Richard will agree with Dr. Naifong, the blood is not like water. The blood has viscous. So Dr. Naifong said, of course, I cannot use the continuity. I cannot use Bernoulli. I need to use, if I don't know if I pronounce it correctly, it's very famous law. It's Basile law. Basile law, it's for fluid, we call it non-Newtonal fluid, which is with viscosity. So if the fluid has viscosity, we cannot imply it to continuity. So we apply it to Basile law. And this is what Dr. Naifong used. What he did, he said, okay, what he did here is Basile law. It's like a logic, If you increase the viscosity of a blood, you're going to decrease the flow. So he put it down, nominator. If you increase the length of the tube, you're going to increase the resistance. So he put it down, the length. If you increase the diameter, it's going to increase the flow. He put it up. If you increase the pressure, you're going to increase the flow. He put it up. Of course, he did not make like this because he derived it from other calculation. And what he found, basiles there, and Dr. Naifong in his experimental study, he found, of course, that the length, the area, the radius, if decreased, because the R is to power 4, that means any small changes, if decreased, is going to affect significantly to the flow to be decreased. Now he assumed after that, without math and without a clear experimental, that while the flow is decreased, the speed or velocity of blood should decrease. In some reasons, the flow is going to be sometimes like turbulence. So that's going to consume some kinetic energy. That's going to decrease the speed. Perfect. he's going to say the resistance of the tube is going to consume some energy. Perfect. We increase the, let me delete this part, I'm sorry. Because I don't want to go that much deeper about this.
You can see how passionate it is regarding this.
To summarize this point is, we need really why we're talking about CVR related to thrombus. And we're talking about stasis, which is many studies showed very strong evidence between stasis, stagnation of the blood, and formation of the clot. We need really to know if the speed of blood around the tube is going to increase or decrease. And we need to resolve, no need to keep saying potentially. The last point, I want to finish with this point, which is a statistical test. It's very important why I'm highlighting 101 or common sense at this point, because sometimes I've seen it from the relationship between the health provider and biostatistics people. Sometimes, we struggle to let the biostatistical people understand our study, because if they don't really and fully understand, they could give us a wrong statistical test. And the principle here, if we have incorrect data, apply it to correct statistical test, the result will be inaccurate results. If we have correct data, apply it to inaccurate statistical test, the result will be invalid results. So a p-value is only meaningful if we have correct data applied to appropriate correct statistical method. Otherwise, the p-value, even significant, is meaningless and can really lead to false conclusions. What I mean, because some authors could say, you know what, but I found p-value significant. How comes you cannot? I can put any formula and then, I found p significant. That means it's really related to. I can do a simple study. I can ask the patients, to measure their circumference and then measure the length of a fridge at their house. They use it, the fridge or the door or anything. And please give me the numbers. And of course, this is inaccurate because my definition, my way, my equation is not aligned to scientific. I can apply it to some of this statistical test and can give me significant value. Because this statistical test is blind. You need to know how to use it. If you don't use appropriate one, it's going to give you wrong and false conclusions. And this is very important. And if I can finish with this, a very nice story for Albert Einstein. I love it. Albert Einstein is one of the most intelligent person in this world. When he did an equation to describe a static universe, all people around him don't believe the world at that time is expanding or contracting, is stable. So he could, in his equations, when he calculated and put his equations, he found the universe is expanding. Oh, no. They will kill him. They will shoot him if he said the universe is expanding at that time. So what he did, he added a constant, cosmological constant, to stabilize his equation. And that constant from his mind, just to satisfy the people around him. After we found a Hubble telescope, and that telescope discovered the universe is expanding, Einstein said, this is my biggest blunder. When we really put our beliefs without scientific rationale or satisfy around us for any excuse, I did this formula just because of that, or I did just because of that, sometimes this action and intervention could be one of the biggest blunder on this topic. and why the importance of pick CVR, and then we're gonna leave it for either for Jennifer or for the annual meetings. We're gonna discuss in details, and we're gonna apply these principles to compare the two valuable studies, and we're gonna give some recommendations on how we can handle the a little bit confusion in the practical area, hopefully in scientific and appropriate way.
Wonderful. That was a lot of information to unfold, but I'm so glad that we have those studies and we're able to come together and really apply it to our practices to have a better understanding on how we can improve our patient outcomes, because it's amazing what we can do in collaboration with each other and highlighting our different strengths. So thank you for that information. I think it's wonderful. I think there's a lot to do with that, and really to consider how we apply that moving forward.
More details in the conference. So if for all the vascular access nurses out there, we invite you to INS in Las Vegas in April. And you can join us for a good conversation and discussion about CVR.
Fantastic. Well, thank you both. I think it's a good way to end today's session. But like they said, if you would like to meet them and talk more about CVR, learning more about their particular study, you can join them in Las Vegas at the Paris Hotel, April 26th to the 29th, where there's also a pre-conference opportunities if you were to come out early. But we look forward to welcoming you. And if you've not registered, we do encourage you to go ahead and register, because the prices do go up as we get closer to the INS annual meeting. So thanks for tuning in today.
Thank you.
Yeah. So thank you, everyone, for joining in today on the INS Infusion Room. Today's infusion knowledge, titled Catheter-to-Vein Ratio, New Considerations in Measuring, with our expert guests, Jennifer and Hammam, has provided us with valuable insights. I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.